Well, thank you for coming today, ladies. I'm excited. This is like our first little workshop, hopefully the first of many. If you don't know me, my name is Stacey. I run Stacey and Fit, which is a women's small group strength training business. I also have the Pelvic Movement, which I am still in the midst of creating, but it's going to be a big community hub of support for women and everything pelvic health and everything women. So things that we don't talk about, things that we need to talk about, things that we are talking about, and we just want to bring everything out to the open so that everyone feels very supported and nurtured. About me, I really like helping my women create strength from the inside out, so I have a big focus on pelvic floor and core, and building that first and foremost, and then putting that through healthy movement and creating healthy movement patterns and building you nice and strong so that you can take that into your daily life. So especially postnatal women, pregnant women, and just rebuilding that foundation. I find there's a lot of women that have, after pregnancy, specifically, we're creating a little bit of dysfunction with our pelvic floor and our breathing and into daily life. So I would like to bring awareness to that so that you can then build control within your own body. We're all control freaks at heart. So the things you can control is building that connection to your pelvic floor and your breathing, and then putting that into really nice, safe and healthy movement. So it's not about weight loss per se, but that is a byproduct of your lifestyle. So if we can create this beautiful movement from the inside first, and then we can peel away the layers of sleep and overwhelm and stress being a trigger for pelvic floor as well, which I'm sure Sarah and Liz will go into. So in my community, I would like to bring in external resources like Sarah and Liz, and build this community where we can offer you a plethora of support, and you're not alone. You don't have to suffer in silence. I want you to be able to reach out and grab onto us in every area of your womanhood so that you feel strong and empowered and you're confident and you get to have you back. You know, I think we lose ourselves, especially when we've had children. So let's bring that back to the forefront and bring it back to you and be in control of you. So that brings me to Sarah and Liz from the Female Physio Co. You lovely ladies are women's health physio, specific to women and our pelvic health and everything to do with women and their fun and amazing things that we maybe don't always want to deal with, but you're there on eyes on the inside. Sarah has this beautiful clinic at Robina, so, and Pilates as well. So you're also doing strength from the inside out. Yeah. And you're here to give us a nice diving deep of what I am capable of sharing with you, and I'll take over afterwards. So I will leave it to you beautiful ladies to provide a more in-depth knowledge. Thank you. That's okay, wonderful. I will give you this. Let's have some sound. Oh goodness.
Alrighty, well thank you Stacey and everyone for having us here today. It's always a pleasure talking to the community and more members to spread the word on pelvic health, and you know, again, like Stacey said, what we don't talk about, which is so common in the community, but just almost we just hide away sometimes. So I think now it's definitely, the word's coming out a lot more about pelvic health, people are a lot more aware of it, but there's still a long way to go. So we're here today to hopefully shed light on some of the things that we experience that we might not want to talk about. Not normalise it, but just make it open and out there, and just remind ladies that you haven't got to, you know, suffer in silence if that's happening to you. So a bit about Liz and I and the clinic. So we have a team of 4 women's health physios at Robina at the ECT Centre, so based 10 minutes away from here. So we all specialise in pelvic health, so we all do women's health, pregnancy, post-pregnancy, all through the lifespan. So paediatric pelvic health as well. We go through obviously pregnancy, post-pregnancy, the pelvic pains, so the endometriosis, adenomyosis, vaginismus, all those sort of pelvic pain conditions. We'll also then travel through to prolapse, incontinence, through the lifespan to menopause, perimenopause, and then beyond that as well. So we do see the whole lifespan, and we wanted to create a clinic that's very specialised in pelvic health, because physios in general, we're so generalist, like we're such generalised specialists, and we've got to be good at everything, where it can be quite tricky because the human body is not simple, it's very complex. So we just wanted to get a really nice, intimate team of clinicians who are really passionate, and I think, you know, I'm very fortunate to have the girls working with us because, yeah, we live and breathe pelvic health, so it's, yeah, very, very lucky. But we have myself, Liz, Erin, and Caitlin as well. And I've kind of gone through all of those.
Yeah, so this is just a little bit of, just a summary of some of the different things that can happen throughout your lifespan and how your pelvic floor kind of interrelates into it. So as Sarah talked about, you know, your pelvic floor can, you know, become something that's, well, potentially need to be focused on even from as early as childhood. So when you're toilet training, when you're, you know, trying to train out of bedwetting, or making sure that your, you know, child is comfortable going to the bathroom and, you know, not being constipated or avoiding the bathrooms at school, things like that. Caitlin, our physio, is very helpful with all things paediatric and like continence based.
And it can be really simple tips to give parents about what, usually parents come in, they've tried everything, and it might be 2 or 3 little extra tips that can make a big difference. So yeah, I think paediatric pelvic health is very overlooked, and it can make a big difference. So.
Yeah, and then of course as we kind of go through, there are, I guess, peak kind of like, or key milestones within a woman's life where you're going to find that at each milestone there's going to be a slightly different kind of pelvic floor focus. So from your first period, we do think about, okay, how is your pelvic floor interrelating into your hormonal changes that you're going through adolescence, through puberty? How are your periods looking? Is that normal? It's really quite often that we, you know, have to remind people it's not normal to need to take a day off because of any sort of period pain or ovulatory pain. Like, it should be something that is manageable. If it's not manageable, we want to make sure that you know who to reach out to. But then as we go through, and as Sarah's kind of figuring out now, I guess that next milestone is around the pregnant and postnatal woman. So trying to figure out, okay, we're obviously going to be going through a whole lot of different changes in a whole lot of different ways, not just relating it to the body, but we try to make sure that we're bringing in that, like, we're just bringing back that focus into that foundation of like, okay, how can we control, you know, the pelvic floor function as your body changes? How can we kind of bring that through to your postnatal period when you're trying to figure out what your new normal is? And as you said at the beginning, Stacey, like, trying to make sure that we're kind of building from like a good, strong foundation and then adding in. Yeah, we can use these kind of milestones as ways to go, okay, this is now a check-in point. Okay, what's happening? Can we help? And then Sarah mentioned as well, then looking into like your peri and your postmenopausal phases, where your hormones are going to change and fluctuate, and that is going to make quite a few different changes to your body, which we'll talk about. But it's another touch-base point where pelvic floor becomes important to make sure, you know, incontinence, leakage, and prolapse are things that we're thinking about and trying to make sure that we're managing so it doesn't impact your day negatively. So, I guess we should start with what pelvic floor muscles are and what is involved within your pelvic floor. So as you can see here, Sarah's doing a lovely job of modelling with your computer. Of course. Where would you like this one? So you girls can see it. Can you, is that better?
Yeah.
Except Carol, you can't see it.
Oh no, that's not.
Sorry. You can see it. So, to make it really nice and simple, your pelvic floor is all of the muscles that kind of go between your pubic bone and your tailbone, and they sit all between your seat bones as well. So you've got this large kind of muscle group, okay, which we're splitting into just 2 layers to talk about. So we're talking about first your superficial layer of the pelvic floor, which does a lot of your squeeze focus for your muscles. So it closes the opening of the vagina, urethra, and the back passage. Okay, and then we have a look at the deeper layer, which Sarah's showing now, which you can see is kind of shaped as like a little like U bend, or just like a U sling of muscles. This does your lift and internal pelvic support. Okay, so if you think about a squeeze and a lift, and this kind of hand movement that we typically will do throughout the presentation, that's the movement that we want from your pelvic floor. And if you're having a difficulty with, you know, being able to feel a contraction or feel a relaxation of your pelvic floor, it's really helpful to kind of know, okay, is it a problem with one layer of the muscles? Is it a problem with both? Are the two muscle layers communicating well together? And it's going to be a little bit overwhelming to do by yourself, which is where we come in.
Yeah, and the pelvic floor is really complex too. Like there's so many parts that we assess when you come into the clinic. We will touch on the internal vaginal exam soon, but I think now it kind of fits in quite well. So when we're looking at pelvic floor, we want to look at how much can you contract and turn it on and lift the pelvic floor, how well can you relax it as well, especially if you're pregnant, how well can you bear down and lengthen the pelvic floor to enter your bowels or push a baby out, things like that. We want to know what the opening width of that vaginal entrance is measuring at rest and as you push down, does it balloon out, get longer, just sort of not move at all, which might indicate some tension internally. We want to look at your perineal body, the space between the vagina and the anus. How long is that, particularly if you're pregnant? If that's quite short, you have a higher risk of 3rd and 4th degree perineal tears. So we take all of these measurements prenatally, but also in any pelvic floor assessment, just so we can get a really good, thorough baseline of what's sort of happening. So yeah, that would be the opening of one measurement there. That's your peri-body measurement there, and then the total length at rest on a pelvic floor squeeze as you push down. There should be a difference in range there. If nothing moves when you sort of try and push down and pull in, again, you might be quite tight or high tone internally, and we can certainly work on that. And if that's the case as well, you might be getting things like incomplete bladder and bowel emptying, urinary hesitancy, constipation, pelvic pain, pain with intercourse, things like that. So a lot of the things that I guess we again don't talk about, but that's sort of the basis of what we're looking at and why we're doing internal exams.
So when we think about trying to bring in, I guess, thinking about contracting and relaxing the pelvic floor, it's a big focus for us to talk about the breathing as well, okay? So your pelvic floor is exactly that. It's a floor of your abdominal pelvic cavity. So you've got your pelvic floor muscles that sit at the base, you've got your abdominal wall muscles that wrap around, and your diaphragm at the top. So even though, yes, it's a very important group of muscles to help with bladder, bowel control, sexual function, and like core support from below, we've got to bring it into thinking about, okay, how is your pelvic floor going to function with your abdominals? How is it going to function with your diaphragm? Are you going to be able to kind of, well, use these muscles all together? Because that's really what's important, is how we're going to use all these muscles in your day-to-day. So if we start as simple as the breath, okay, and if I just have both my hands here for pelvic floor and for diaphragm, as you breathe in, okay, as you breathe in, your diaphragm is going to move down to allow your lungs to fill. So breathing in, the diaphragm comes down, the belly expands, the pelvic floor also descends at this point. And then as you exhale, the diaphragm comes up, the belly comes in, the pelvic floor also comes back up to its resting position, okay? So it's really important to remember that, yes, we talk about can you switch on and switch off the pelvic floor, but it's a dynamic movement. It's got to be able to work with your breathing, okay, to kind of expand as you inhale to allow some more space within the belly, and it's got to be able to gently contract as you exhale to help with core recruitment and kind of making sure that you've got that right stability, I guess, with exercise and other movements in the day.
And your diaphragm is part of your core as well, so often there's a lot of focus around your pelvic floor, but sometimes we tend to forget about our diaphragm. So if you are someone who is doing exercise, for example, and you're holding your breath, you're sort of not working this part of the core. You kind of, yeah, you might be working engaging the pelvic floor and letting it go, but you're not working the entire core. So it's kind of like driving a car with 4 gears and one's not working. It's just not as efficient, and it can create some stiffness in your pelvic floor if it's not moving and mobile very well. So that's why our biggest thing we always harp on about is the breath. So most clients who come in will talk about breath the whole time, intertwined with everything else, but you'll see it all comes back to the breath.
Yeah, and the good thing is, if you're having a problem with your pelvic floor, or if you're having a problem with engaging your abs, like, yes, you know, the core can become a little bit complex, but it also means we've got a lot of different ways to cue you and find out what's going to work best to engage your core. So if you're struggling with your pelvic floor lift, we can talk about, okay, on that breath out, we know that the pelvic floor is going to be lifting anyway, so just focus on breathe out and do your exercise or do your movement as you exhale, okay? If your pelvic floor function is not your strongest cue, gentle to take a nice deep breath in and out to help relax yourself between, I guess, your high impact exercises if you're having a rest break.
And what also happens when you do take a big breath in, if you're breathing into your belly particularly, the second you breathe in, your abdominals, diaphragm, pelvic floor, they all lengthen. When you exhale, they will naturally contract just by exhaling. So if you simply go, on that exhale, I'm not trying to physically pull everything in, but they're just turning on anyway. So if you forget to activate pelvic floor, feel my ribs moving down, breathe out during an exercise, when in doubt, just breathe. Breathe out on the exhale, breathe out on the effort, breathe in on the easy part. That's kind of a really nice way to just get started because it can be very overwhelming. Yeah, fun have a little bit.
So, when we're talking about contracting the pelvic floor, let's go through a couple of cues that, well, I really love to use.
This is a very good question that putting into layman's terms, very good analogy, so get ready.
So I guess the real big thing to think about is, like, we're talking about, yes, a movement as simple as a squeeze and a lift. There are two parts to it. But you're going to find that there's going to be a cue or like a mental or a visual image that just works best for you. So I'm going to run through a couple of different cues that I use with clients. And if something works best for you, feel free, please give your pelvic floor contracting exercises a go if that's something you're okay to do.
Can I do it almost just like saying it? So you probably all are anyway. And breathe it with us too.
So you can think, and remember, breathe into a pen, breathe out to do the exercise. But you can think about doing a pelvic floor squeeze to stop the flow of urine or try and hold in a fart, okay? That physical feeling of closing the entrances to help stop a flow of urine is probably one of the most commonly known cues for pelvic floor. So squeezing to hold urine, to hold wind, okay? Another cue that I really like, which kind of just makes sense to us gals, is if you have, or if you are a person who uses tampons, do a pelvic floor squeeze, like you're trying to lift up a low-lying tampon. Like you're trying to kind of draw that tampon up and in and let it go as well, okay? So you can think squeeze as if you're trying to lift a tampon up or grip a low-lying tampon and make sure you can let it go. Other cues that I like, we talk about squeeze and hold your pelvic floor muscles, almost like you're trying to close off the opening or like close doors, okay, around the vaginal space. Or if you don't like that feeling of like a door closing analogy, you can think of zipper. So starting at your back passage as you do a pelvic floor squeeze. So you inhale to prepare, and as you exhale, think about almost like you're zipping closed from back passage all the way up even to your belly button, like you're trying to do a zipper up.
Let's just keep going. So
I'm looking at So the other thing is, if you've ever tried to get yourself into like a really skinny pair of jeans or some leather pants, God forbid, that kind of like drawing in and up to try and get that zipper on, that gives you a little bit more of that kind of abdominal cue to work your pelvic floor. And for some people, they will have an interaction between that lower abdominal tension and pelvic floor. So if you feel a little bit of it, it's okay. Just don't let it be the sole focus of the exercise.
I often like using that jean zipper effect with exercise. So if we're teaching like isolated pelvic floor activation, we'll often go with the first cues we use, like holding wind, we pulling up a tampon with exercise. We want their deep core, their T8 to also engage. So using that jean zipper where you start from down here, exhale, pull up like you're wrapping your hip bones together. That works well for a gentle activation. So we don't want to be pulling it in for dear life, the gentle.
And speaking of gentle activations, if you're a person who does struggle with that quick switch on of the pelvic floor muscles, and that can be something that you're just like, I don't know, it kind of feels like I can get there eventually, what you can think about as a pelvic floor cue is imagine your vaginal space as a straw. And if you're trying to squeeze your pelvic floor muscles, it's almost like you're trying to drink like a really dense thick shake up through the straw and let go. If that's ruined thick shakes for anyone, I apologize. But like, remember that's slow drawing up and letting it go at the end.
It's ruined, never again.
And I can keep going, but let's just not ruin food for everyone.
So let's touch a little bit on relaxing pelvic floor. Again, we could talk forever on this topic, but we'll just try to touch on just to give you guys some cues on how to feel, let go. It is a really hard, I find turning off is harder than turning on in some cases. Unless you're really weak, you can't initiate the general first contraction. I find if you can get that first contraction, that's easy. It's turning off and turning it off all the way, that's the tricky part. And that's again where our breath comes into it. So I always often use the cue, breathe into your belly, feel the breath go down to your pelvic floor, like you're lengthening your perineum. Now the perineum is that space again between the vagina and the anus. So from here, so if you're thinking about breathing into your perineum, just think about that space there lengthening. And then exhale, pulling it back in. Now if you find you're someone who actually turns on pelvic floor, but you're quite overactive where it's like almost stuck, I would say inhale to your belly, feel the breath go into your pelvic floor to lengthen that perineum, like you're almost pushing out some wind a little bit, because pushing out is okay to a very small degree. And then as you exhale, don't exhale and pull in all the way. Just pull in like 20%. So the brain knows what it's on, but what's the difference between on versus off. So inhale like you're pushing out some wind, lengthen your perineal space. Exhale, pull in gently. Inhale, straight back off. So the emphasis goes to inhaling off rather than exhaling, pulling up. That's just one way. Everyone's very different. It's sometimes easier when you have your pelvic floor assessed with a finger in there. You can feel feedback of the finger lifting up and down and lengthening a lot more. So you can also sit onto a rolled towel where you feel your perineum lengthening and relax into the rolled towel, then exhale, pull off the towel, and sink back into it. There are heaps of different cues. So
even if you're sitting like on your chair at the moment, if you are able to uncross your legs and you're comfortable with leaning forward, you can even think if your pelvic floor muscles are facing down towards the chair, okay, as you breathe in, you're thinking, how can I lower these muscles, the muscles that are sitting between the seat bones that you're currently feeling on your chair. If you breathe in, can you lower the muscles between the seat bones closer to the chair? Okay, so breathing in and breathing out.
Visual cues help too, like a flower shoot coming out, flower shoot pulling in, octopus head, whatever sort of.
I'd like to talk about oh, this is a jellyfish or an octopus. Jellyfish.
So whatever floats your boat, Miles loves fish and like wild. It's whatever you want to call it. But yeah, I'm going to stick with octopus because it just works for me.
We want to think that jellyfish, as you think, like if a jellyfish was floating along in the water, it's going to kind of flatten, it's going to open. Okay?
Yeah, it's like an octopus, like tentacles.
Okay, we're making the octopus work, but as we're kind of floating along, we're going to get that gentle opening, and then if we're needing to do a squeeze, yes, we're going to have, you know, the jellyfish, the octopus come in nice and thin to kind of propel, but then we're going to open again. And you think about that kind of soft lowering or that floating of the sea creature down towards the base or the floor of the ocean. Okay.
Anyone who has any questions, feel free, please just jump in. We'll have it at the end as well, but if it happens sooner rather than later, then feel free to jump in.
Can I just say, if the baby starts crying, I'll just go to the back of the room and walk around.
Oh,
Absolutely fine.
No, I do. Next up, we're going to just touch on some signs that you might have some pelvic floor concerns. So we might start with bladder. So bladder, the obvious one, incontinence. Whether you have incontinence when you have the urge and you rush to the bathroom and you leak on the way, you might leak, you might do your wee, you might get up of the toilet, walk away and then leak after the toilet. You might leak when you cough, sneeze, laugh, jump, lift, cry, vomit, any of that. Vomit, yes. Yeah. So it can happen on those big impactful movements. You can have mixed incontinence too, where you have the urge and the stress combined. You can have, like I mentioned earlier, urinary hesitancy. You can get deviated urethral stream, so you might find that where it just goes to one side the whole time. They're probably the biggest ones. Bladder, you can get bladder pain, so pain when you have to empty your bladder, pain on emptying. The pain might go away once you finish emptying your bladder. That's a big one as well. That kind of comes with pelvic pain.
Yeah, so
Is that quite high up?
it can be, yeah. So if you're getting any sort of like bladder pain or pelvic pain, when we talk about it, we're typically saying anything that's kind of sitting like even from like between kind of hip bones down. It can sometimes come up as high as the belly button though, but pain in this sort of area is a referral point from your pelvic floor. So if it's something you're, if what we're saying is kind of ringing any bells for you, if you have ever been a person who's experienced like UTI type symptoms without actually having any sort of urinary tract infection, then it can be something that your pelvic floor causes. But I mean, for the most part, like bladder function, if you're struggling to hold your wee, if you're struggling to empty your wee, or if there's any difficulties with like you're not feeling like it's complete or comfortable,
Go back again, just try and wee again 5 minutes later.
Yeah, that's usually things that can be helped or looked into from a pelvic physio perspective.
And it can be really behavioural too with our bladder. Often we find we get into this habit of going just in case, or we might wee in the shower do all because we know we probably shouldn't be doing, but we all do them, and it can become a really bad habit. So weeing in the shower, for example, when we're standing up, if we're weeing in the shower every time, our brain gets so used to it when we hear running water while standing, oh, that's time to wee. So we might get more urgent at the kitchen bench, doing our dishes, whatever we're doing, running water, standing up. That might be a bit of a trigger. So that's kind of an example of how it can be a bit behavioural.
Yeah. We also, when we're talking about pelvic floor dysfunction, it can also affect the bowels. So quite a lot of our clients may not always start off by having bladder symptoms, but they'll start with having signs of chronic constipation, not being able to fully empty their bowels, or having pain or struggling to kind of relax enough to pass that bowel movement. You can also have fluctuating bowel movements, where sometimes it's a little bit harder, but then other times you kind of get into those kind of softer, almost diarrhea type states, and that can then sometimes be impacted by your pelvic floor, because when your pelvic floor is contracting, remember it's trying to hold on to a bowel movement, it's trying to stop you from passing wind, so you can get bowel dysfunctions that come about from it. You can also get abdominal and gas kind of bloating pains. So if the person feels quite distended through their whole kind of stomach as well as bowel, especially if it gets worse on an urge to go past a bowel movement, that can be potentially related to your pelvic floor.
And we didn't mention it at the start, we probably should have. The pelvic floor primary role is to contract and have a resting tone to contract the whole time, to hold in wind, wee and feces, and that has to be able to relax in order to pass those three things. So many other functions, but that kind of leads us to why there could be an issue, whether it's not relaxing, therefore you get constipation, incomplete emptying, things like that. But yeah, with bowels you can also get the feeling of having to empty your belly, you can't get it out. You might need to push up against the perineum or put a finger inside the vagina and push the poo out. You might struggle to hold onto your wind, you might have fecal incontinence, fecal urgency, fecal soiling in your underwear, an hour after empty your bowels, wiping too much.
Absolutely.
The wiping side of bowels.
Yeah, if you say you wipe more than 3 times, Sarah's going to see
It's like 0 is nothing. And if you wipe and there's nothing, that's like a perfect poo, just FYI. Yeah, so if you actually, because we have what's called a closing reflex with our anal sphincter, so you should be emptying your bowels. Your anal sphincter should literally close straight away. That's a closing reflex. And if it's weak, it won't fully close. But if it's working well, it closes straight away, and you almost have nothing on paper when you're wiping.
That's such bad news. I thought
It is really bad news. Hey, however, disclaimer.
I remember one of my friends was like, "I was a little toilet paper," and I was like, "What do you mean?" And
Do
then
you
she
know
just
what?
didn't say anything.
Disclaimer. So there are three possible causes why you might be wiping. 3 main causes why you might be wiping more than you should. The big one is stool consistency. If you have diarrhea or soft stool, if you go to like wiping more, that's kind of irrelevant. So there's something about a good poo, like we did bring out a stool chart, but sometimes good poo where you wipe and white, that's not normal. But if you have a really soft stool, you will wipe more anyway. And if you have hemorrhoids or skin tags, the fecal matter gets stuck behind it, so it might be messier anyway. Or if you have that weak anal sphincter, so the weak closing reflex, where it won't close all the way, you just wipe it until the cows come home. So they're kind of the main reasons as to why you wipe more than you want to.
So, if anyone needs to have a chat after this, we're available. But then if we kind of go into as well, like your sexual function side of things, so this is, look, probably a passion area of mine to talk about, but like your sexual function is super important with your pelvic floor. So if you're experiencing any kind of, I guess, pain with insertion, and look, yes, we talk about sexual function, but even pain with inserting a tampon or pain when you're getting a pap smear, like if you're getting anything that's causing you pain or soreness or discomfort around the area, it can be caused by your pelvic floor, because these muscles are designed to close off the openings and hold, and we need to be able to relax and kind of open the pelvic floor to be allowing for any sort of internal penetration or movement. If we go more into like the sexual dysfunction side of things, you can have hypersensitivity or soreness of the skin of the vulva, or you can have pain that's actually internal and deep within the vaginal space itself. Some people, about 10 to 15%, will have a uterus that is flipped back or retroverted, and we talk about that as being something that sometimes can cause pain, but that's not a given. Okay, so if you do have a retroverted uterus and you are experiencing kind of this deeper pelvic pain, it's really good to have an assessment just to make sure that it's not actually any of the muscles that sit towards that deeper kind of area of the pelvis, and just gripping, yeah.
So we can do muscle releases too. So like if you had a sore back and you went to see physio and you've got the elbow in there, we can do the same thing, obviously with one digit,
Not with an elbow.
But that's what we mean by if you have elbow activity, it can actually help by releasing the muscles internally for your bowel function and bladder function pain.
Yeah. And again, it's something that, look, if you're worried or if you're concerned, and even as well, if it's not an issue with pain, even if it's just an issue with like you're not getting, you know, an orgasm anymore, or you're having a change to your ability to actually feel internally sensation, arousal, orgasm, these are things as well that the pelvic floor is a part of. So we're more than happy to have a chat. As I said, I love chatting about this stuff, so if that doesn't.
And then yeah, we have all the prolapse symptoms too. So the vaginal heaviness, vaginal bulge, and that can happen anytime. It could happen just with exercise. It could happen at the end of a long day, being on your feet, looking after all the kids. It could be post-intercourse too. You might feel that heavy aching feeling as well. Often with a true clinical prolapse, you've got to have that bulge feeling. So heaviness can be mistaken for overactivity and increased tension, where there's so much pressure in the pelvic floor. So your heaviness may not be a prolapse, it might be that you can't let go.
Yeah, you might have like the floor coming up to meet the rest of your pelvic organs. So that is going to create pressure, that's going to create resistance. So a heavy feeling may actually be the floor coming up, not the pelvic organs coming down. So it's, again, something that we can, within a session, be able to help kind of distinguish the difference between and give you that idea of what's going on. Otherwise, we'll talk about it a little bit more, I guess, with like when we talk about pregnancy, postnatal. There's other things as well involved, I guess, with your pregnancy and postnatal journey that we look into.
I might just rush through the next slide quickly. I am worried about time. But the next one's talking about our pelvic assessment. So I mentioned briefly about the vaginal exam, but when you guys are booking in for your first session with whoever it might be, pelvic health physio, they'll get you for an hour long, because the history that we need to get can replicate and can solidify what we might find internally or via our physical assessment. So we want to know all the things we just spoke about. We want to know if anything that's happening. So what are your bladder habits like? What's your fluid intake like over the course of the day? How often are you doing a wee during the day versus at night time? Do you have urgency? Do you leak? All those things we will screen you for. We'll screen for general medical history, sexual history, function, prolapse symptoms, exercise history. What does your day-to-day look like? Are you lifting constantly? Because that obviously will impact pelvic floor quite a bit if you are having pelvic floor symptoms. So we'll go through about half an hour of questioning in the start, and in that sort of subjective questioning, we will be sort of educating on what we might need to tweak in terms of what might be normal versus what's sort of considered abnormal. That's for the first half an hour, and then we'll do the internal exam. So again, it's with everyone's consent. It's not doesn't have to be done, but like I sort of touched on before, it does give us a lot of information, especially when you're pregnant, if you are looking to have a vaginal birth, or if you want to go and do a weightlifting comp and you've never lifted weights before, and you want to try and get your PB. That's fine. We really don't want to tell clients to not exercise because, as you guys probably know, it's so important for every part of our life. So we want to try and get clients to that point of what their goals are, what they want to do. And then we do an external assessment as well, so we're going to look at their hip function, range of motion, things like that.
And then from there, we'll have a chat to you within that first session about, after the deep dive into your personal life, and of course, again, you tell us as much as you're comfortable with. But once we've done that, once we've done an exam, we've got a really good understanding of you and how your pelvic floor is interacting with your day-to-day, so we can start your treatment and your education and everything from that first session typically. But I guess if you're ever worried about it, you're more than welcome to have a chat to us about, what to expect if you're coming in for your first appointment.
We'll always tell you exactly what we're doing with our finger as well before the assessment, so you guys know what to expect. And at any point, if it's too much, we're always reassured to say no, stop, and we will stop straight away.
Yeah, I think
so everyone's got fatigue in there.
I've just switched over to our slide about prolapse. So probably the most common thing that we see or have people come in for their first appointment about is that feeling of a heaviness of bulge. We talked about, it could be your muscle tension that's actually causing that feeling of heaviness, but it could be your pelvic organs becoming a little bit more lax. And there are quite a few reasons we'll go ahead with talking about as to why they become lax. But a prolapse in itself, we're talking about a softening of the connective tissue that supports either the bladder, the uterus, or the bowel itself, okay? So a prolapse is when these organs start to move internally more than we expect, okay? Or potentially start to come externally, where you can, physically see or feel a lump, a bulge, a pressure, a golf ball kind of sitting inside that wasn't there before, okay? Prolapse is very slow to kind of progress and occur, but at those milestones that we talked about at the beginning of our talk, following on from your first period, where your hormones will dictate, the movement that your pelvic organs have to pregnancy, delivery, and postnatal journey. That's going to have a huge impact on how your pelvic organs are sitting, because your whole body has a new posture over the course of 9 months, and then gets the world flipped on it for the next 9 to 12 months after. And then especially again during menopause, where you have that drop in your female hormones. Again, we'll talk about that as we go through it, but at each of these points, we can find that the pelvic organ position starts to kind of press into the vaginal space. There are 4 different stages of pelvic organ laxity and pelvic organ prolapse, and we only typically diagnose a prolapse if you are at a stage 2, okay, where there is laxity of one of the pelvic organs or one or more that is heading in towards the opening. So if it's sitting within about a centimetre of the vaginal entrance, that's when we start to diagnose that stage 2 prolapse. Anatomical change, but it needs to be accompanied by a functional bother. So, an issue with your bladder function, bowel function, leakage, or again, that feeling of a lump, bulge, or something sitting there. So, yes, a prolapse is anatomical and it is movement that is more than what we expect, but it also has to be combined with that functional kind of impact or bother in your day-to-day. You can have a stage 1 pelvic organ laxity, which is where the pelvic organs move internally, okay, a little bit more than we expect. So, you know, if you're pushing down, we see or we feel, depending on, you know, if we're doing an internal exam, we can feel that one wall starts to move down, but not within that first centimetre of the opening. So if you have that little bit of internal movement, and that could be normal for you, but that would be what we call a stage 1 laxity. It's only when it starts to come down to the entrance and give you functional bother symptoms that we start to diagnose laxity as prolapse.
And key to remind you guys as well that when we assess for prolapse, we assess you when you strain. So we get you to, right, hold your breath, push, and like you're pushing out a big poo. That's what we measure you at. So you might not be, your bladder or bowel or whatever's coming down, may not be sitting at the entrance there at rest. It's only really when we assess it and it comes down, that's a stage 2. It definitely might be sitting at rest, and then it might bulge out to stage 3 or 4, which is more severe. But we're talking about when you push down, so that's why it's not great to strain with your bowels, to hold your breath whilst you lift heavy weights. It's got to come at the entrance when you strain, but also you need to have those symptoms. So if you might come into the physio for a general check if you have no real symptoms, and we might see you have a stage 2 prolapse. It's not the end of the world, because a prolapse, we know it's very subjective and it's very symptomatic. So if you have no symptoms, half of us will be walking around with a stage 2 prolapse and not even know about it. It's until it interrupts our daily life. But obviously, if you had it but didn't know about it, it's good to know about. So if you do find you get sick and you're blowing your nose and you're coughing, but you're not really engaging the pelvic floor whilst you're doing that, you might be preventing, or you might be weakening pelvic floor whilst you're coughing excessively, or straining with your chronic constipation, or holding your breath whilst you're doing your 1 hour rounds in the gym, or things like that. So it's just, with prolapse management, it's over the lifespan. We don't fix prolapse. We can help symptoms, but we can't fix the fascial defects that have caused the prolapse without surgery. So we know surgery has quite high recurrence rate, so we need to be able to manage this throughout the lifespan and not get constipated, not straining.
Think about your pelvic floor in the instance of prolapse as an orthotic that you put in your shoe. It's going to be, if you have a good, strong pelvic floor, it's a very supportive orthotic. It's going to be something that lifts up the pelvic organs, closes the opening more firmly. It's going to reduce any of those functional bother symptoms, okay? And it's going to help us have better bladder, bowel, and sexual habits, okay? So we're not re-stringing everything up, but what we are doing is providing that base support so that you can get on with function through the day. There are a lot of risk factors as well if you are worried about prolapse. There are a lot of risk factors, and if you are ticking off the list of a couple of them. So with a vaginal delivery, multiple vaginal deliveries, yes, is a risk factor, but even if you had a vaginal delivery where there's been, potentially like a higher grade of perineal trauma, if you've had a birth weight of baby above 4 kilos, if you have been pushing, and I don't mean in labour, but I mean actively pushing your baby out for more than about 90 minutes, okay? These are all things that can weaken the pelvic floor and also put stretch on the connective tissue that is what is supporting the pelvic organs up, okay? And as Sarah said, it can be pregnancy related. It can be, chronic coughing. If you're quite sick for quite a long time, there is that. Yeah, there is that pressure coming down onto the pelvic floor. Chronic constipation, so not being able to empty the bowels, holding on and having this extra pressure building up. And again, as we go through menopause, we do lose that softness and that stretchiness of our pelvic tissue. So menopause changes will potentially lead us an increased risk for prolapse.
We might just go over pregnancy just really quickly for the next one. So obviously there's a lot of changes in pregnancy. It can be a lot harder to engage pelvic floor with all the pressure. So you might find early days, first 20 weeks, you can still kind of squeeze like you normally would when you're not pregnant, but toward the end of your pregnancy, you find it's hard to turn it on to the ability you could pre-pregnancy. But you might find endurance gets a bit weaker, you can't hold it for as long, your coordination comes all over the show. The hormonal change as well in pregnancy can cause this softening pelvic girdle, which can create weakness anyway. And that's why we do emphasise seeing someone, ideally a women's health physio pre-conception, see what your baseline's like, come back in their second trimester, get another exam done to get new baselines. And then post-pregnancy, we can have a look, right, you started here, you got to here in pregnancy, and now your pelvic floor is at this strength, or now we can hold it for 3 seconds, and we could have held it for 10 seconds previously. So having those regular checks in pregnancy can be a really nice way to just be goal oriented and just know that you're coming to see a physio for a reason. You know that things have changed and it's not just coming in to get checked and off you go. It's very goal focused. And
Abdominal separation as well during pregnancy.
yeah, of course, which doesn't have any effect on pelvic floor, but obviously it's a whole different area itself. So we'll register for that in pregnancy and postpartum as well.
Yeah. And also just a quick note on exercise during pregnancy, like we've said a lot of things about your pelvic floor and how we want to be engaging it to exercise. It is safe to be exercising in pregnancy. So as long as what you're doing during pregnancy reflects, what you were previously doing. So we're trying not to, aim to kick as many goals as possible. We're trying to maintain your personal records already. So if you were exercising previously, we're wanting to make sure that you can continue that through your pregnancy to as best or as close as your non-pregnancy kind of levels of function were. And if that for you is, going for a run every single day, we want you to be able to run every single day during your pregnancy.
If you can, if you don't have the floor, you can take that. And
yeah.
everyone's so different. The guidelines have come away from being very strict because we want women to be active as much as possible if you can in your pregnancy.
So I guess with our postnatal assessments then, we've already touched base. We want to see you after to figure out what your new baseline is following on from the changes that you've had. So typically we'd like to see you as soon as 3 weeks if you're comfortable. So at 3 weeks postnatal we can do your abdominal wall check, we can do an external visual assessment of the pelvic floor to just make sure that you're engaging correctly and that we're actually seeing that you're starting to get that on-off squeeze function back. And again, start to just kind of set the groundwork for you to be able to return back to, the exercise that, brings you, joy, that keeps you strong, that keeps you just mentally sane, especially after having kids. Yes.
Doesn't 3 weeks still apply if you have a second-degree tear?
Yeah. If anything, if you have a second degree, or if you have a third or fourth degree tear, those high grade tears, we kind of want to see you definitely by the 3 weeks, because at that point we want to just make sure your scar tissue is healing, there's no signs of infection. We of course, as I said, we keep everything external at that point because we don't want to add infection risk. But by doing your pelvic floor exercises, it helps promote the healing after any sort of perineal tears or trauma, because it helps with circulation, it helps bring the muscle fibers closer and back together, and it gives you more support. So yeah, good question.
And all that aside too, yes, we assess your birth, how that went, and what your pelvic floor rehab program looks like, but also ab separation. We want you guys getting back in exercise as quick as possible, as safe as possible. There's none of this whole wait till 6 weeks anymore. So previously we would say rest for 6 weeks, at 6 weeks, now you can start doing some low impact exercise. That's out the window now because everyone's level of fitness is so different, which we all know. So if you're someone who is dying to get out and do something, and we can do low impact from the get-go if it's comfortable for you, and if you have no symptoms, and if you have a history of being quite active, and which we will screen for at 3 weeks postpartum. We want to work on ab separation, recovery, and rehab as early as we possibly can. So we don't want to wait until 6 weeks. That's why we get the week.
Yeah, totally. That being said, 6 weeks is still a more than okay time to see us, especially if you just need that time. There's a lot of things that are going to be changing through that postnatal period. So if you just need time to get a bit of a routine together, attempt to get some sleep, come see us definitely at 6 weeks if you weren't feeling ready at 3, and we can do your full pelvic floor check by then. So we can do an internal assessment at 6 weeks. We can again check your abs, make sure that if you have started exercising, that we're making sure that it gets more challenging for you, because challenge creates that improvement. And yeah, if you haven't started your exercise by 6 weeks, fantastic. If you're ready for it, we'd love to be able to help you get there.
I've just skipped over the ab separation in pregnancy part because can get quite in depth, but on the screen there's a bit of a rough guideline of postnatal expectations of return to exercise. So often, like I said, first 6 to 12 weeks even we do low impact exercise. We want to work on general strength again, especially functional strength, like squats, for example. We're squatting up and down all the time, we're holding a baby off a chair, onto a chair. So bodyweight goblet squats are a great one to do postnatally, but obviously a lightweight, bodyweight first and then adding weights in. And then depending on your level of fitness as well, we can go back into high impact, so jumping, running, bounding, anywhere from 10 to 12 weeks, depending on the person. We always make sure you get cleared by women's health physio first prior to doing that. But that's a very rough guideline of sort of what we like to see postpartum.
Yeah, but as we said, like the sooner we can get you back to doing the exercise that you love, the better. And as soon as we can get someone to help kind of supervise you to make sure you're hitting your goals as well, the better. Whether that's us, whether that's Stacey, like we want you to be able to feel safe and supported with the type of exercise you do.
I just noticed time, so I've just brushed through the last one. So we might finish it up there. We do have the hormonal changes about menopause to talk about, but we will kind of get the gist. We did mention that throughout the presentation. But if anyone's got any questions for us, I'm sorry the last bit was a little bit rushed. We've gone through a bit of tangents, but any questions that you guys have, or Stacey would come up and do your pelvic floor.
Yeah, I can do that after questions if anyone's got any. You're also more.
I was just wondering, with exercise, crunches, sit-ups with prolapse, that kind of thing, or preventing it.
So lying down, by the way, is actually a really good position if you are, like if you do have a diagnosed clinical prolapse. Lying down pelvic floor exercises are great to do. So if we're thinking about then taking that further and trying to do a crunch or sit up or something like that, if you've been working on your pelvic floor in a lying down position to help with prolapse, pelvic floor squeeze, exhale as you lift the head up into the crunch. It is something that you should be able to do. If you aren't sure though, or if you're not feeling quite right, we can actually assess that in the clinic. So if we're doing a lying down pelvic exam, we can just, visual or just get a visual of when you're lying there, like lift your head, can we see any downward descent? So if you're worried, we can at least give you that reassurance of, okay, it's holding, we're stable, we're doing well, or hey, we might need to work on doing a pelvic floor squeeze here. So,
but also because you're anti-gravity. So when you're lying down, so if you do a crunch, we've got articles to show you that by you doing a crunch puts way less pressure on the vagina than doing a squat because you're against gravity here.
So this is a whole standing.
It's a really funny thing that a lot of us aren't really aware of, but if we're doing a crunch, we're lying down, so gravity is on our side here. Secondly, we go into standing. That's why a lot of women might find that when you're in standing, doing lunges, squats, step up, so you might feel your symptoms more. Crunches, yes, we'll check, but you're probably going to be fine.
You're lying like this, like if anything, your bladder, your bowel, your uterus, the things that are potentially prolapsing, they're just hanging out off to the side. They're not coming down, they're hanging out.
Unless you're excessively holding your breath and going, and literally pushing down whilst you're doing a crunch, yeah, you might impact it a little bit, but only to a small degree.
Yeah. So, see if you'd like, but it's good news. You should be able to.
What age do you usually see children, say, I've got a little girl who's got severe constipation, she's 5, but she's had it since she was 2, actually probably younger. So we've tried everything and we still maintain with Movicol and do that, and then kind of it's good for a week so go off it and then it builds up again. Do you have, I mean, probably we're already doing it, but I just thought, do you have a recommendation, or an internal check is probably recommended for
no internal for paediatric clients.
Yes.
Do any internal at all, but Caitlin can see kids from infants, all up through to.
And the other thing is, no, we don't do the internal assessments with your paediatric clients, but we do have options as well for, we can walk you through, okay, this is, and we walk through your child as well, because, it's important that they understand what's going on, but we walk them through, okay, this is what we do for a good poo, this is the breath work that we use to help pass the poo, and we can, if necessary, especially sometimes when they're a little bit older, we can even have a look at doing biofeedback. So
often we don't do any internal, any external visual check of pelvic floor when they're a child. But a lot of it's behavioural, but we can see, Caitlin can see clients from as early as 6 months. But like Liz said, it's really about the behavioural side of things. So it's educating the kids in a way that I cannot. Caitlin's got a knack of teaching kids in layman's terms to a whole different degree. Layman's terms for adults is one thing, but for kids it's quite challenging. Yeah. So once the child can understand a little bit more, maybe the parents as well, we can give you guys a few tips. That can make a big difference, but yeah, definitely not just.
Yeah. But yeah, there's also some really fun books that Caitlin has in her room now. Lots of poo. But yeah, feel free as well if you do need to reach out. We include we've got some flyers as well. You're more than welcome to kind of email us, give us a call, book in. Of course.
There is 10% off for all of you guys as well. So everyone's 10 cents. Grab a flyer for 10% off the initial assessment too. So feel free to grab one.
Oh, I'm going to take it over to you.
Yes. Yes.
Cool. Thank you. I just thought we would finish with something functional, because that's what I do. So they do the inside stuff and the fun bit, check you off and leave you and send you to me and I supervise you. So that's how it works. So I just thought it was perfect that you touched on squats, because that's what I was going to cover. We all have a chair, we're all sitting down, so people at home, you can find a chair, and we're going to come up to stand, and we're going to do the breathing that you talked about. We're going to create that functional movement with breath. So if you just take your feet just wider than hips, so you can feel the full whole foot on the floor, and just keep your chest up, and we're just going to sit down. And then you're going to place all of your weight through your feet, and you're going to come and stand up. We do this all day, sometimes with a baby. So what we're going to do is take a nice natural breath in to prepare, and then when we breathe out, we're just going to connect with our pelvic floor. So like we're drawing up that tampon, it's like a 5% lift. Okay? So we're going to take that into movement. So we're going to breathe in naturally, and we're just going to come and sit down. And as you breathe out, I want you to feel your sit bones on the seat as you breathe out, and just gently lift your pelvic floor up and breathe out to stand. So we're creating a functional connection between your pelvic floor, and as you're breathing out naturally, we're lifting up. So you can capitalise and control that natural lift up. And when we were talking about possibly having that dysfunction after pregnancy and after birth, the natural breath should bring your pelvic floor up. And then during training, sometimes we forget to breathe correctly. So if I can teach you to breathe correctly, and then in a separate exercise, we can really learn to control that pelvic floor with a physio and with me. When we're doing this functional movement in your daily life with something in your arms, particularly a baby or shopping or something, you're consciously breathing in a correct way, even if it's unconscious or subconscious, shall I say. So if you'd like to do a couple of movements with me, we can do it together. So just take a natural breath in to prepare. We're going to sit down. And we're going to breathe out, lift, and stand. Breathe in. Breathe out, lift, and stand. Does that feel okay? Do you feel conscious? Can you actually feel your tummy muscles engaging when you stand up, rather than just like, and then just not consciously getting up or struggling to get up? You can feel your whole feet on the floor. You can feel your sit bones on the seat, and you have that control and that conscious feedback. So I know we're really short on time, but I wanted to leave you with an inner thigh stretch, because I know that inner thigh is directly connected to pelvic floor, and a lot of women are presenting with quite tight pelvic floor and unable to relax pelvic floor, which in my line of work, not necessarily the same as pelvic floor, but we are all mothers. We are all working full time, or we'll go back to working full time. We'll start hitting our 40s, and we'll start drinking wine, and we'll start doing all things, and we'll create overwhelming stress in our life, because we need to provide, we need to pay the bills, we need to do the things, we have children, life's crazy. We're forgetting about relaxation. So if I put it hand in hand with relaxing your pelvic floor consciously and putting it into a stretch that makes you feel like you can have 2 minutes of downtime to reconnect with your breath, breathing in, letting your belly hang out like you've had a big feed, and really letting everything just fully relax. And then breathing in, breathing out, breathing in and just being there for 2 minutes. So if you would like to join me to do that, you can. I would suggest laying on the floor with your legs up the wall, and we open the legs out so that we have our inner thigh stretch. People at home can do that, but if you ladies would like to sit on the floor, and we will just sit on the floor. We're going to have our legs out nice and wide. We're going to try and sit up nice and tall. I'm just going to gently take the length of our spine and walk it forward until we feel a nice inner thigh stretch. You can gently flex your toes and have your knees nice and soft. And we just sit up nice and tall. We can sit here and breathe. I really like this stretch for your inner thigh. The other option is, which I'm not going to take you through because we're in the hall, is just being in child's pose with your knees wide and your forehead on the floor and stretching your internals and just breathing. So if you just like to close down your eyes and just be here, the more you lean forward, the more you're going to get through the inner thigh. I'm just going to breathe in deeply to the belly, let the belly hang out, fill with breath. Fill all the way up to the rib cage, all the way up to the collarbones. And then breathe out, empty the collarbones, empty the ribs, empty the belly. Breathe in to fill the belly, fill the ribs, all the way up to the collarbones. Exhale, empty the collarbones, empty the ribs, empty the belly. Breathe in, fill the belly, lengthen your spine. Breathe out, soften, let it all go. Just see if you notice those thoughts as you breathe, popping into your head. Just push them to the side. They'll be there when we're finished, and you can give yourself this time, 2 minutes to yourself. You can just be here and stretch. Breathe. It doesn't necessarily matter what position you're in. Just give yourself 2 minutes a day to sit here and be. You find that you're particularly tight in the inner thigh. It might be that you could be particularly tight on the floor, that you're just holding all that tension and stress. Just keep breathing deep into the belly, filling up the ribs, sides, back, top, all the way up. And empty from the top, empty the ribs, empty the belly, feel that belly empty. And then really breathe in, fill all the way up, sides, back, top. Empty from the top, empty the ribs, empty the belly. Breathe in. Breathe out. Thank you, ladies. Thank you. Thank you. Just want to give you 2 minutes peace to a day, and I would like to invite you back up here. You ladies can zen out on the floor. Thank you very much. Thank you for having us. Thank you everyone for joining us.
Thanks for coming, guys.
Thank you,
guys.
Yeah.
And that's a wrap.
That's a wrap.
Thanks for